First, my department is Department of Respiratory Medicine and Medical Critical Care. So we have 40 normal beds, we have a 12-bed intermediate care unit and a 14-bed intensive care unit. The department is divided into several divisions. The most important is lung transplantation. We perform about 150 transplants a year, and we take care at the moment for 1,800 patients in follow-up. In Germany, every patient who has received transplantation in the center is followed-up by the center till death. And our dropout rate is below 1%. So we take care for our patients for the rest of their life. We improved with 1-year mortality last year to our best result ever. We have a 93.8% 1-year survival, so only a 6.2 1-year mortality. We are not as good in the long-term survival. We have a 5-year survival, and I call it organ survival, not patient survival, because the retransplant rate now in our hospital is between 8 and 10%, and mainly the younger recipients, cystic fibrosis, for example, they are retransplanted several times. The 5-year organ survival is about 70%, the 10-year organ survival about 55%. It's a little bit related to the age of the patient during transplantation, so cystics live longer than COPD patients due to the comorbidities, which will be a topic too. We have a second huge division, which is pulmonary hypertension. Marius Höcker, who is my substitute as department head, is a specialist in pulmonary hypertension, and we take care for about 600 patients in the pulmonary hypertension outpatient department. We have pulmonary oncology as every respiratory department in Germany. We take care for about 1,200 patients with bronchial cancer and other thoracic malignancies. We built up last year a department for interstitial lung disease. Antje Brasse moved from Freiburg to Hannover for an associated professorship, and we have now interstitial lung disease and mainly idiopathic pulmonary fibrosis outpatient clinic. And my own topic is respiratory infectiology. We have Capnetz as the community-acquired pneumonia cohort. We have now a big bronchiectasis cohort, which is run by Felix Ringshausen. And we have a huge cohort of adult cystic fibrosis patients, so we take care for about 300 adults with cystic fibrosis. And this is the background. We have about 3,500 outpatients every 3 months. So most of our work is in between the outpatient department. What is very special in Hannover, we discussed it. We built up 10 years ago our own rehab center. We have our own rehab center for the respiratory department, mainly for the transplant patients. One of my seniors is now the head of the rehab center, and we send all of our transplant patients for rehab before transplantation and for rehab after transplantation into our own rehab center, which has been a huge step forward because this is our SOPs, our standards. There is a close collaboration. Everybody knows what the others are doing, and this has improved our quality by far. So, Capnetz. Capnetz is the community-acquired pneumonia network in Germany. Capnetz has been funded by the German Ministry of Research. Sometimes funding policy in Germany is not easy to understand. We have different sources of funding. the most important one for basic research is the German Research Society, DFG, Deutsche Forschungsgesellschaft, which is focused on basic research and the preclinical programs. And we have the German Ministry for Research and Education, BMBF, which is responsible for structural infrastructure programs. And they set up a program which has been called competence networks in internal medicine. And the main reason was to stimulate cohort building. And there have been about 15 different networks, from lymphoma to Alzheimer's disease to Parkinson, hepatitis, and also community-acquired pneumonia. And the community-acquired pneumonia network is a network which connects hospitals. So about 30 hospitals in Germany report their community-acquired pneumonia cases into a database. The database is a web spirit database. It's an online database. You can put in every patient into the mask of the database, and about 80 pneumologists and general practitioners in free practice relate to the database. We now have 12,000 patients in the Capnetz database. These patients are followed up for 6 months. So we have mortality data after 6 months for each one. And we have, besides the data, we have specimen, pathogens, blood, EDTR blood, so blood and serum, urine specimen, and for about 5,000 of the 12,000 we have extracted DNA and RNA in the biobank. The biobank is in Hannover, is part of the Unified Biobank of Hannover University, which works with regard to the modern standards. Capnetz is ongoing. After being funded by the BMBF, it has been moved into a foundation, and the foundation has a number of sources for being financed. One is, again, grants from the most important public grant givers, so DFG and BMBF, for different projects. Second is business with the pharmaceutical industry, so we sell our data and sell our bioprobes, our specimens to the pharmaceutical industry. And so third is, it is a foundation, and if patients who have suffered from pneumonia want to give a grant, this is possible. This is something which is not very popular in Germany. It's totally different from the United States, where everybody who has money gives 10% as charity money. But it's coming up in Germany as a lot of people becoming older and older do not have children and do have nobody to handle the money over when they die, and so charity is on the table now. It's a discussion point in Germany, but it's much easier to get charities for cancer in children than for any infectious disease. So that's the problem. So that's what Capnetz is. So I forgot the last point. Capnetz is now part of the German Center of Lung Research, DZL. And the German Center of Lung Research is funded again by the German Ministry of Research and Education. And this combines the 5 best respiratory sites in Germany. which is Munich, Heidelberg, Gießen, the so-called North collaboration, which is Hamburg, Kiel, and Lübeck, and Hannover. And these 5 had been selected in a 2-step application process and approval process, and there is a funding of 25 million euros a year for the German Center of Lung Research, so about 5 million for every site. So Hannover gets about 5.6 million, and Capnetz is a so-called associated infrastructure, and the DZL pays for the database and the biobank of Capnetz. So this is one of the sustainability processes. Now, medicine, not infrastructure. And I will present you a very typical patient. 2 days before admitted to our emergency department, cough without sputum production, fever. A day before, increasing dyspnea. The fever has been increasing and she recognized chills, and she visited the general practitioner but was only treated symptomatically with antipyretics. To be honest, this is not typical for Germany, so most of the general practitioners prescribe antibiotics. However, she did not get an antibiotic, and the major reason is this. This is a grammar school teacher, and teachers are very special in Germany, and a lot of ideology behind what they do, and she was absolutely against antibiotics, so it's poisoning, and therefore she convinced her general practitioner not to take it. Important issues from the history. She had suffering from an asthma from childhood on. She is on regular therapy with Serotype, 2 puffs a day, which is 500 of fluticasone a day. It's an important issue. She's married, 2 children, her mother and one of the daughters also suffering from asthma, and the younger daughter has suffered from an otitis media a week before. Well, what does this history tells us? First, is there a risk of inhaled steroids for community-acquired pneumonia? It's quite clear for years that there is a risk of ICS for COPD, but is it the same for asthma? It was for a long time thought it's not, but the problem is most of the asthmatic patients are much younger than the COPD patients, and the prevalence of pneumonia is lower in the younger age group. So this is the first study published in November last year in chest, demonstrating a very good analysis from a huge UK population database, demonstrating that there is the same risk for pneumonia, an increase of 2-fold in patients with asthma, and this is dependent to the dosage of inhaled steroids use and dependent to the kind of inhaled steroid. Fluticasone has a 5 times more higher risk than budesonide, and bectamidazole is a little bit in the middle of these. So 500 of fluticasone is a real risk factor for a severe community-acquired pneumonia. These are the clinical signs and symptoms of the patient. High respiratory rate at rest, no sputum production, something positive during auscultation, tachycardia, temperature, and low blood pressure. Well, what is necessary to stratify these patients as a patient at risk? And there are different ways how to stratify patients with community-acquired pneumonia, and I want to start with etiology. First, we have a number of pathogens which are responsible for community-acquired pneumonia, and still the most important one is strep pneumonia, pneumococci. It's not quite sure whether this will be the same during the next years, because pneumococcal vaccination now is more and more popular. Pneumococcal vaccination is now not only in children but also recommended for the older age group. We have the 13-valent pneumococcal vaccine, Prevnar 13, which has been shown, the data will be published very recently in the New England Journal of Medicine, which has been shown to reduce the prevalence of pneumonia by 50% for the serotypes which are covered by the vaccine. And I saw days ago the first data from the UK database for the last 3 years demonstrating that there is a real decrease of pneumococcal pneumonia, mainly in patients who are hospitalized. So we have to be very careful what will go on with the etiology of community-acquired pneumonia. So looking to these, this is a study Tony Torres and myself published 2 months ago in the ECMID journal out of a symposium we had last year, again demonstrating that all over the world strep pneumonia is the most important pathogen. And it's quite clear if this is invasive pneumococcal disease, if there is a bacteremic episode of pneumococcal disease, mortality is still high. And what we expect out of all databases available is if there is septic pneumococcal disease, we still stay with a mortality between 16 and 20% worldwide. And this has nothing to do with resistance or something else. Even in susceptible strep pneumonia, mortality is high, and the major reason for this is the pathogenicity of strep pneumonia, which is one of the most pathogenic bugs we know. Staph aureus, is this really a community-acquired pneumonia pathogen? And the answer is yes and no. If you look to the prevalence in the huge databases, Staph aureus pneumonia is rare. It's between 1 and 3 to maximally 5% of all pneumonias with a known origin. However, Staph aureus plays a role in patients suffering from severe viral disease and mainly in influenza patients. And this is a very classical example. Young patient coming to our intensive care unit with this CT picture. It's necrotizing pneumonia. It was a PVL, leukobucidine positive Staph aureus, which is very pathogenic. And she had suffered from influenza. It was during the H1N1 pandemic for 4 days, and then Staph aureus was a secondary bacterial infection. So this is something which is discussed very controversially. At the moment, my personal feeling is about 90% of all pneumonias need a viral trigger. So first it's viral infection, and one of the major post-immune response mechanisms to viral infection is the stimulation of interferons, and stimulated interferon decreases the ability of the host response to act against bacteria. So invasive bacterial infection is much more likely if there is a viral trigger. The most important viral trigger is influenza, but it's the same, for example, with RSV. RS virus, which is more and more coming into adultship. We see a lot of RS virus infections now in adults. We see a lot in transplantations. It's a real problem for lung transplantation. And also RS virus, adenovirus, parainfluenza virus, they are the basis for a secondary, more bacteriemic bacterial infection. Mycoplasma, this is one of the first Capnetz data. We looked to our mycoplasma patients. We used mycoplasma PCR for diagnosis out of throat swabs. And what we detected is mycoplasma is really the infection of the younger people. The mean age is 30 to 35 years of age, and not 70 as it is in the rest of the patients. And most of the mycoplasma infections are very, very easy to overcome. No problems, not a difficult course of the disease, and they are self-limited. We look to patients treated with ampicillin or other penicillin derivatives with mycoplasma, and 99% of them recover. It's individual host response. There are a very small number of mycoplasma infections who are severe. There could be immune complex disease with mycoplasma, and there could be myocarditis and endocarditis due to mycoplasma. This is something which you have to take into account, and in clinical practice, the most important and easy to get parameter is tachycardia. If you have a pneumonia patient which is doing better from the respiratory side but stays tachycardic with a heart frequency above 100, it's likely to have cardiac involvement, and you have to take care very, very thoroughly for these patients. Legionella, well, Legionella is a pathogen, a gram-negative pathogen. There could be a high mortality in patients who are seriously ill. You have to be aware that not each Legionella infection is really serious. There are a lot of mild Legionella infections which are never detected before, because you do not perform a Legionella microbiology in any way. But what we think today is, if a patient is more severely ill, if he needs observation or he's on an intensive care unit, Legionella antigen in urine is a standard diagnostics. And the reason for this is the standard treatment for Legionella is moxifloxacin or levofloxacin, a respiratory fluoroquinolone, and mainly observational studies here out of Spain, during the Murcia pandemic, for example, has demonstrated that fluoroquinolones are better than macrolides for Legionella. What is open is how long to treat. Nobody knows exactly. My personal feeling is 2 weeks minimally. The more severely ill patients for 3 weeks. And what is also open is what to do with treatment failures. That's really a difficult to answer question. What you can do is you can add rifampicin as a combination partner to the fluoroquinolone. The fluoroquinolone macrolide combination seems not to be effective in Legionella in any way. And what is really important, you have to achieve good serum concentration, so you need IV treatment. If there is a treatment failure, oral therapy has to be avoided. Gram-negatives, well, even in our times, the number of gram-negative pneumonia in outpatients, and this is a huge difference to hospitalized patients, is very low. It's somewhere between 3 and 5%. It's different in different parts of the world. If you look to Asia, about 30% of the patients is Klebsiella pneumonia. This is something you have to have in your mind if a patient comes back from a holiday in Bali or Thailand or Korea. The Klebsiella rates in these countries are up to 30%, much higher than they are in Europe. The reason may be infection control situation, hygiene situation. It's not well known, but classical Klebsiella pneumonia is not rare in Asia, not in the Arabian countries. Important for you here in Spain, if the people come over the sea from North Africa, the gram-negative rate is much higher than it is here in Europe. Here in Europe, the main risk factors are nursing home residents and patients who are fed via a stomach tube or something else. They have an increased risk. And one of the risk factors we were not able to detect because we have not documented carefully enough is the use of proton pump inhibitors. PPIs increase gastric pH, and an increase in gastric pH is a risk factor for gram-negative colonization of the stomach. PPI patients are more likely to get gram-negative infection. This is something you have to take into account. Second point, severity assessment. We perform in Germany the CRB, so-called CRB 65 score. C stands for new confusion due to the infection, respiratory rate, blood pressure. It's clear that the systolic blood pressure is enough. You do not need the diastolic one. And the age, and in the English-spoken countries they use the so-called CURB score and add biochemical parameter, the blood urea. If you are a 0-point CRB patient, you can be treated normally as an outpatient. If you are 2 and more points, you have to be admitted to the hospital. If you are a 1-pointer, you have to start thinking what to do. One of the main problems with regard to pneumonia is a disease of the elderly. These are the figures from Germany, the mortality figures. Santiago Ewig published some years ago, and what you can imagine, there is an increase in mortality with age. Not a surprise, but there is a remarkable mortality even in healthy young patients, and there is not a 100% mortality in the above 90 year of age patients. This is very important. When a patient is old, the age is not the only reason to withdraw therapy. And that this is a real problem. I will show you, I do not have it with me, this slide. Okay, that it is a real problem we know again from the Capnetz database, because we looked who is on monotherapy and who is on combination therapy, and more of the elderly were on monotherapy, but more of the elderly are more severely ill and they had to be on combination therapy. So there is a withdrawal in our mind. We decide to treat not as intensively the elderly not as intensively as the younger ones, and this is really wrong. You have to decide to treat or not to treat, but if you treat, you have to do it as recommended. So there's not a decision possible like a little bit pregnant. You are pregnant or you are not pregnant, and you treat or you do not. One issue which for me is very important is even mortality is higher in the elderly, there is a mortality in younger patients. And this is a study out of Capnetz looking which patients are at risk if they are younger, and the most important issue is comorbidity. So if this is a type 1 diabetic, if this is heart disease from birth on, if this is severe asthma, these are patients at risk for more severe pneumonias. And these patients are overseen in clinical practice because they are young and they are able to cope some of the clinical signs and symptoms of pneumonia very good. So be very careful in younger patients. And if one of the CRBs or one of the curve factors is positive in the younger patient, you should admit it to hospital. Because these are really patients at risk. And they die under very traumatic conditions. What are the main factors for intensive care admission? No question, if you are ventilated or if you are in shock, that's intensive care. From the other factors which has been mentioned by the international recommendations, there are two which are, in my mind, most important. One is hypoxia. If you are hypoxemic, you are at risk, no question about. And the second is the multilobular infiltrates. As more infiltrates are recognized in the chest X-ray, as higher your risk for severe course of the disease is. This is a subgroup analysis of our MAXET study, which was a mono versus combination therapy in severe sepsis study. And I only show you the data for community-acquired pneumonia. If you are a CAP patient in shock, mortality is 33.2%. This is a higher mortality than the mortality for nosocomial pneumonia in the MAXET trial. So CAP with shock is a very, very severe disease, and you have to take it into account. Back to our patient. This is the chest X-ray with a lobar infiltrate in the left lower lobe. These are the biochemical parameters. No question, CRP is sky high, so she's ill. She has an increase in blood glucose, even she is not known to be a diabetic. She has an increased serum urea. She is slightly hypoxemic and she is slightly hypocapnic. This is an important issue. This is an analysis out of US database looking to hypocapnia and hypocapnia as risk factors for mortality. No question about, if you are hypocapnic, you suffer from chronic respiratory disease, and this makes a pneumonia more severe. This is not really surprising. But if you are hypocapnic, you also have a more than double-fold likelihood of mortality. And why is this the case? So if you are hypocapnic, this means you are able to cope your hypoxemia by increasing your breathing frequency, but you will be exhausted in a reasonable time frame. So hypocapnia is a very sensitive risk factor for severity of pneumonia. And blood gas analysis, not only pulse oximetry, but also CO2 measurement is something which has to be included into the emergency room. Second, blood glucose, a paper from the Capnetz group, published by Gernot Rode, demonstrating that under infectious disease conditions, blood glucose can increase. This has nothing to do with diabetes. It's a clinical sign of metabolic derangement. And as more deranged you are, as higher your blood glucose is, and as higher your blood glucose is, as higher the likelihood of mortality is. So if there is an increase in blood glucose in the emergency room, this is a patient at risk. And as more it increases, as worse for the outcome. Procalcitonin, I did a lot of biomarker studies, and to be honest, I'm no more in favor of these biomarkers because sensitivity and specificity is so low. And one of the major problems of procalcitonin is it's expressed organ specific. If you look to the lung, 0.05 is the threshold. If you are above of 0.25, it's more likely to be bacterial pneumonia. If it is intra-abdominal infection, 0.25 is nothing. So you have to be up to 1 or higher. If you see a severe pneumonia with very high procalcitonin levels, every time it means you are in multi-organ failure because the procalcitonin is a signal for tissue hypoxia and not for the pneumonia itself. If you are brain dead, procalcitonin is sky high, 500 and more in patients who are brain dead. It's not a marker of infection in any way. If you suffer from endocarditis because the heart does not have procalcitonin in any way, procalcitonin is 0. It's not a marker for endocarditis. If there's endocarditis with an increased procalcitonin, you know there has been infectious embolism into the spleen or into the gut or into the brain, because this makes the procalcitonin. So to work with procalcitonin means you have to know a lot about the physiology of procalcitonin, and this makes it really difficult to use it in clinical practice. Comorbidities. And this is absolutely my favorite study, a study of my good friend Julio Ramirez from Louisville in Kentucky. Kentucky is a very good federal republic in the US because Kentucky is the site in the US with the most metabolic diseases. The mean body mass index in Kentucky is 34.1, the mean. And 60% are smokers. So if you think of Kentucky, it's a fat cowboy sitting on a horse with 2 cigarettes in his mouth. So that's Kentucky. And therefore Kentucky is very good to look to comorbid conditions, and this was Julio's first study demonstrating that in patients with severe CAP, about 15% had a cardiac event during the hospital stay. This is absolutely logical because there is an increase in inflammatory parameters, which means an increase in coagulation. And if you are suffering from an arteriosclerosis disease, you will get complications. And this has been confirmed by a number of studies. Here's another one published in Circulation. The same in patients. This is the number of cardiac complications: myocardial infarction, cardiac arrhythmia, and left heart failure as a signal of septic cardiomyopathy. And this is really important to say. If there is a treatment failure in pneumonia patients and you have chosen the right antibiotic, please look whether there is a different diagnosis. And most often it is a cardiac one, but it could also be a derangement in diabetes or a thromboembolism and a pulmonary embolism. So comorbidities are very important to take into account for differential diagnosis. Are there biomarkers for this cardiac disease? Stefan Krüger, who worked for Capnetz for a couple of times, looked at a number of data. The best parameter is really adrenomedulin. Adrenomedulin is a marker which measures, on the one hand side, endothelial dysfunction, so it's a cardiac marker, and on the other hand side, it's a marker for bacteremia, a septic marker. An increase in adrenomedulin stays for a truly septic patient and also for a cardiac dysfunction, and therefore the performance of adrenomedulin is better than the performance of procalcitonin. But to be honest, the performance is not good. And if all these markers are cost effective, I have my doubts. So at the moment, we work very, very old-fashioned with C-reactive protein. And we look how the clinical course is, and we do not use biomarkers as a standard diagnostic measurement. Okay, setting. You all know there has been a discussion about healthcare-associated pneumonia coming up with the ATS guidelines in 2005. And the ATS stated, if a patient has a lot of contact with the healthcare system, if he is treated with antibiotics, if he has been hospitalized more often, if he is a chronic dialysis patient, if he is in a long-term care facility, he is like a nosocomial patient and he has to be treated like a nosocomial pneumonia. But from all data which are available now, this is not true. You have to look to antibiotic pretreatment, and you have to look to prior hospitalization. These are signs for nosocomial pathogens. But the nursing home itself, it's not. If you are a nursing home patient and you do not have the risk factors I mentioned, your pathogen is Streptococcus pneumoniae. And these are data from Spain, so it's the same in Southern Europe than it is in Germany, in Middle Europe, and there are only a few others, and this has been shown by the Capnetz database. Again, a study Santiago Evic was responsible for. We do not see a lot of multi-drug resistant pathogens in our database, and this is a suggestion Santiago and myself did in a recent Lancet Infectious Disease paper. Do not look to the setting, do look to the risk factors of the patient. Is there comorbidity? Is there disability? These are patients who are more likely to suffer from gram-negatives. What does this mean in terms of treatment? First, strep pneumonia. A lot of retrospective data, again here the Capnetz data, which demonstrated beta-lactam macrolide combination is more effective than beta-lactams alone. And this has been shown here in Restrokos data out of the CAPU database, and this is the first prospective study now, which has been financed by the Swiss National Fund and has been provided by the Genève group, demonstrating that there is an advantage also in a prospective randomized study of beta-lactam macrolide combination to beta-lactam alone. It's not a mortality advantage in this study, but much faster improvement of the patient when using the combination therapy. And there are two reasons for this. If you add macrolide to the beta-lactam, you cover the atypical pathogens. This is one. It's gap closing. And the second one is that we now know that macrolides have anti-inflammatory properties. And two are most important. They are very, very good interleukin-8 antagonists and reduce granulocyte trafficking into the lung. So they are immunomodulators. And on the other hand side, they have an influence on gene regulation in Pseudomonas and other non-fermenters. They drop down biofilm production in these pathogens, and therefore we now use them as maintenance therapy in cystic fibrosis and in bronchiectasis patients, and they are very successful. The question which is open is how long do you need a combination with the macrolides? And to be honest, in my mind, if it is not a typical pathogen, you only need it for 3 days. Then these anti-inflammatory properties have been gone. So you could then de-escalate to monotherapy. Fluoquinolones, are they as effective as combination therapy? We do not know, because there's absolutely no study with the right comparison. However, if you use fluoquinolones, you have to use levofloxacin and moxifloxacin. Ciprofloxacin, Cipro, is a very bad pneumococcal, anti-pneumococcal drug, and therefore it's not recommended, clearly not recommended for community-acquired pulmonary infections. You can use Cipro if there is a microbiological testing and an antibiogram, but not if you do it as an empiric therapy. And this is out of Jordi's group, looking in an observational analysis to macrolide and fluoquinolone combination therapy, beta-lactam plus, and demonstrating that macrolides were more effective than the fluoquinolones. And again, there are a lot of unpublished data. This is a disadvantage that negative results are never published. A lot of unpublished data demonstrating that there's absolutely no anti-inflammative effect of fluoquinolones. Even moxifloxacin does not have an immunomodulatory effect, but macrolides have, and this may explain the benefit of the macrolides. And I talked about Legionella, and I want to come back at the end, so to gram-negatives. And what are the most important gram-negatives in community-acquired pneumonia? It's first and most important Klebsiella, and then it's Haemophilus. And Pseudomonas and other gram-negatives are very rare. Pseudomonas is common in patients who are chronically colonized with Pseudomonas. The very severely ill COPD patients, the bronchiectasis patients, the post-transplant patients who often suffer from chronic Pseudomonas colonization. But in a patient without risk factors, you never will find a Pseudomonas pneumonia. That's a very, very rare event, and because this is a case, you do not need to cover Pseudomonas in your empirical treatment. Only in patients at risk. We have an overuse of anti-pseudomonal drugs for community-acquired pneumonia. This is not necessary in any way. And you have to be aware that the anti-pseudomonal drugs are all not very good on the gram-positive side. Ceftazidime is terrible on the gram-positive side. It's a very bad pneumococcal and staphylococcal drug, anti-staphylococcal drug. You never be allowed to use ceftazidime empirically as monotherapy. because it's so worse on the gram-positive side. Piptazo is better, but it's also not the ideal anti-pneumococcal drug, and the same is the case for carbapenems. So no question about it, they go for strep pneumonia, but they are not the best, and they are much too broad. So if you choose an antipseudomonal drug for community-acquired pneumonia, you have to have very good reasons for this. If it is Pseudomonas pneumonia, and this is more the case in nosocomial pneumonia than in community-acquired pneumonia, mono or combination therapy, this is still an open question. No good drugs. Every randomized controlled trial is not in favor of combination therapy. All what is in favor for combination therapy are questionable subgroup analyses. If you use combination therapy for Pseudomonas, it is beta-lactam plus aminoglycoside or beta-lactam plus fluoroquinolone. What is better? From a theoretical reason, aminoglycosides are bad because they are not really good blood penetrators. And the tissue levels of aminoglycosides in the lung are very bad. However, these studies are in healthy volunteers and not in really ill patients, and mainly not in pulmonary infectious patients, because the barrier between the blood circulation and the lung is different if you suffer from a pulmonary infection. So my personal feeling is aminoglycosides are not so bad, but you need an adequate dosing. And the dosing is for gentamicin and tobramycin minimally 6 per kilo body weight, but we use 8 to 10 and sometimes up to 12. And we monitor it, and we want trough levels below 2. However, if the trough level is too high, we does not reduce the dosage, we prolong the interval. Because aminoglycosides are peak level antibiotics and need this high initial doses. And this is the same for amikacin, and we are now up more between 25 to 30 milligrams per kilogram per body weight for the amikacin. Fluoroquinolones, you can use it. Cipro or Levo are Pseudomonas fluoroquinolones, but be aware you need these high dosages to achieve good levels, and this may be one of the major problems if you use ciprofloxacin or levofloxacin as an oral compound. 500 cipro two times a day, the pulmonary levels are forget it. So you never can treat a real Pseudomonas infection with oral ciprofloxacin or levofloxacin. Let it be. But it's the most popular indication in Germany for cipro, but it's rubbish. Gram negatives. And we have a problem with ESBL, you have a problem with ESBL, and we have a problem with carbapenem resistant bugs. That's how it is. And I will at the end give a short overview. What shall we do? I will leave our patient and will skip this, and I will come to the problem of the gram-negative infections as it is at the moment. So again, this is very important. Antibiotics in the intensive care unit at the highest dosage recommended, and sometimes more than the highest dosage recommended. Because you have 3 problems in intensive care. High cardiac index and much better metabolism of the drugs. Increased distribution volume. Look to the astronauts which are laying in your beds, so the drug is going into the third space and not where you want it to be. and low albumin, so reduced plasma protein binding, which means you have higher free concentrations in the beginning, but they are metabolized, and you lose drug concentration in the second part of the day, and therefore you have to increase the dosage. And this is a very good example. It's Julio Ramirez's tigecycline study, the phase 2 study sponsored by Pfizer. And look, this is the recommended dosage, 50 milligrams a day. This is the higher one, this is the highest one, 150 a day, 200 a day. And the 200 a day achieve good serum concentrations, not the other ones. And this is strongly correlated to the clinical response. So if you are not high enough, you have a problem. So I want to go to the gram-negatives. I will pass MRSA because it's not a main problem. ESBL means carbapenems. Carbapenem overusing means carbapenem resistance. And be aware, you are absolutely at risk here in Spain, because you are in your surroundings, there are hot topics for carbapenem resistance. Greece is 90%, Italy is 70%, the Arabian countries all are 90%, the Asian countries are 95%, South America is above 50%. So you are in the middle of the globalization of this problem. And there had been a very, very interesting study in Eurosurveillance a year ago. They looked to visitors in India. And when they returned to Europe, 25% were colonized by carbapenem-resistant strains. They were not ill, but they were colonized. And if these patients undergo surgery for diverticulitis or for whatever, you have this strain in your hospital. And this is a major problem. And what we know now, very new data, is that these resistant strains, Klebsiella and coli, could be transmitted by endoscopes. So you have to go back to the old aldehyde disinfection, because the new disinfectants are not effective, and these strains could survive in endoscopes. We had pandemics in German hospitals, in Italian hospitals. Patients after duodenoscopy are infected in a row. An outbreak, and the reason where bronchoscopy, endoscopy, coloscopy, so be very, very careful. This is the first thing you have to look to if you have an outbreak of carbapenem resistance. Is there an endoscopic maneuver? Carbapenem-resistant strains let you die, so that's a real problem. This leads to the revival of old drugs, one maybe tigecycline, but in higher dosages. Tigecycline works for carbapenem-resistant strains, it works for vancomycin-resistant enterococci, but it does not work for Acinetobacter. Even if it is susceptible in the antibiogram, it does not work. There is resistance development under treatment, so never use it for this indication. And then colistin. What we learned about colistin is you need a loading dosage. At the moment recommended is 9 million loading dose. You need a maintenance dose. In Germany we use 9 million twice a day for pharmacokinetic properties. Twice a day is better than 3 times a day. The Italians are now up to 15 million. And well, I worked in antibiotics for 30 years. If the dosage is going up and up and up, you will get a resistance problem. It's how it is. And is there any additional benefit of inhaled cholesterol or of inhaled antibiotics? We do not know. There are no well-done randomized controlled studies. There are some studies, for example, where is it? There are some studies which are observational, but there's no clear proof for this. And in my mind, and I said it in the morning, that's a big problem. Due to the increase in resistance, we more and more have observational studies. But observational studies are hypothesis generation. They are not good enough to prove the concept. And cholesterol is totally metabolized by tank dialysis and chronic venous hemodialysis. So you have to stay with the doses and not to reduce it when using this. And these are the aerosolized studies. So I will stop at this point. I'm open for questions. I hope you have something you will take with you, and if you have criticism, please do not hesitate to ask me. Thank you very much.